that, shall we? Other principles of care, you want to make sure the systolic blood pressure meets protocol criteria because one of the side effects of it being a vasodilator, right, is it will inadvertently drop the blood pressure, right? You're dilating those blood vessels, the blood pressure is going to drop. So you want to make sure their blood pressure meets whatever criteria it is for your protocol. Ours is at least 100 systolic before we can give it. Uh, make sure the patient does not have Viagra or any kind of similar drug for erectile dysfunction within 48 to 72 hours. Why do you think that is? Patients had ED drugs. Why do you not want to give them nitro?
Don't the two drugs react with each other?
Right. So they're both vasodilators, right? They both widen the blood vessels. So essentially, you don't want to stack two vasodilators on top of each other. You're going to end up bottoming their blood pressure out. Uh, and in some areas, you're going to have to make sure your medical direction has authorized the administration of the medicine, whether it's via online orders, meaning you called them and asked for permission, or whether it's a standing order or a protocol where you can administer it without uh, talking directly to a physician. After you give one dose of nitro, you can repeat the dose in 5 minutes if the patient has no relief or only some relief. So, like say their chest pain's at a 10, you give them a nitro and it goes down to an 8, right? We can repeat the dose in 5 minutes. Uh, Systolic blood pressure remains greater than 90 to 100. So, they want that top number needs to be at least 90 to 100. We prefer 100, right? So, if you give them one nitro tablet and their blood pressure goes down to 80, we're not going to give them another one. We don't want to continue to take that blood pressure going in the wrong direction, right? We don't want to add to the problems they're having. Or if medical direction, if you talk to them and they authorize another dose of the medication, you can give it then as well. The kind of the standard for EMTs is you can only give a maximum of 3 doses of nitroglycerin, right? So you want to reassess the vital signs and ask them more questions about their pain after each dose. You want to give it to them, give it a minute or two to work, reassess their vitals, see if they're still in pain. If their blood pressure does drop, say with that first dose, you want to treat for shocks. You want to elevate their feet, administer oxygen, keep them warm, right? And until that blood pressure kind of returns to normal. The half-life of it doesn't last exceptionally long, 10 minutes-ish, I think. Um, so it will start kind of coming back to normal after a little bit. And then you want to transport promptly. If we've given nitro, they need to go to the hospital, right? Any questions so far? So some other cardiovascular disorders we talked about. And so anytime we have heart problems, there's a number of disorders that we could be talking about that are affecting the heart. So anytime you get there and a patient says, "Well, I have heart problems," or they have heart problems, what kind of heart problems? There's so many different types of heart problems we can be talking about, right? So they can have coronary artery disease. So coronary artery disease, CAD, sometimes you'll see it spelled out like that. It's a condition that narrows or blocks the arteries of the heart. So it's kind of like a plaque buildup, right? Uh, Usually it results from a fatty deposit or buildup on the inner walls of the arteries. So that's that plaque, that fatty buildup starts kind of narrowing or blocking off arteries entirely. Uh, as a result, it restricts the flow of blood it can cause some chest pain, it can cause other issues. It can lead to a myocardial infarction or heart attack, right? Uh, sometimes it's hereditary. Sometimes the person's completely healthy, but they have a history of cardiac disease in their family. It's hereditary. It was passed on to them. Sorry about your luck, right? Sometimes it's age related. Sometimes blood pressure. So high blood pressure can lead to increased risk of coronary artery disease, obesity, or being overweight, lack of exercise, high cholesterol, smoking. All these things lead to a higher risk factor for coronary artery disease. Then something else you'll probably run into quite a bit is angina pectoris. All right. So angina is a form of chest pain that's caused by insufficient blood flow to the heart. Usually it's due to narrow arteries, secondary to coronary artery disease. Uh, Usually it's during times of increased myocardial oxygen demand. So what that means is like you're working or you're exercising or your heart rate gets up, right, and you start having chest pain. Okay. You start working outside, you start doing some sort of physical labor, you start having chest pain. So when the myocardial oxygen demand increases, because there's some sort of insufficient blood flow going on there, you start having chest pain, right? Most times, patients who have been diagnosed with angina uh, have nitroglycerin prescribed to them because it's a common problem. They take a nitro, they're fine, right? So nitro will dilate the blood vessels. The heart has less blood to pump, less resistance to pump it, uh, and it will resolve that chest pain pretty quickly. A lot of times too, once a person's rested for a minute or two, their heart rates come back down. They're not as exerted. A lot of times it'll kind of start going away on its own as well. So like it says there, if symptoms subside with rest, it's most likely going to be angina pectoris. Anytime a patient's having chest pain, however, we're going to assume it is an MI until it's proven otherwise. And we can't prove that otherwise in the field. Even paramedics with a 12 lead, we cannot prove that it's not a myocardial infarction. The only definitive way to do that is through labs and enzymes and everything else they have to do at a hospital. So you want to consider administering oxygen if necessary, administer nitro and aspirin, to a 12 lead EKG if you have that capability at your service, and then transport. So an acute myocardial infarction is a fancy medical term for a heart attack, right? So acute MIs can occur when plaque causes a ruptured aneurysm of a blood vessel, or narrowing of a blood vessel causes the blood flow to be blocked, causing an occlusion to a major artery, a major blood vessel. Uh, a clot forms, it's called a thrombus, causes blood flow by formation of a clot on the surface. Uh, that can sometimes break loose and cause an embolism, which is another whole other problem. Uh, Emboli can occlude blood flow downstream in a smaller artery. Uh, so when that happens and it blocks that coronary artery, either via thrombus or embolism, it's considered an acute MI. Now the heart is not able to flow the blood as it should. Okay. So there's nothing moving through there. It's blocked off essentially, just like in patients who have had a stroke, when that ischemic stroke, okay, and you have that clot that has blocked off blood flow to the brain. It's the same thing, but in the heart. So now there's an area of the heart that's not being perfused, it's not having blood flowing through it. It's called an acute myocardial infarction. So there's the area of the infarct, right? There's the area that's kind of being blocked off. It's the area that's going to be affected by that acute MI. Uh, Acute MIs can cause ischemia, which lack of oxygen to that area, right? It can lead to injuries of cell and cell death. We know that cells need oxygen to survive, right? So without being able to perfuse the blood through there because of a blockage, the cells in that heart will die. You start causing cardiac death. Uh, it can disturb the electrical function of the heart. So an acute MI can throw somebody into a very weird rhythm. Uh, it can send them into a ventricular rhythm or an atrial rhythm, right? It can cause some very severe problems. It can cause a mechanical problem with the heart. It can cause a patient to go into shock. Uh, and sometimes it can even cause a patient to go into sudden cardiac arrest. Uh, Now, sudden cardiac arrest doesn't always mean you have a chest pain, drop dead right then, right? So we consider sudden cardiac arrest to be cardiac arrest that occurs within 2 hours of the onset of chest pain symptoms. So we consider that to be a sudden cardiac arrest. So while it's very, very serious, if a patient is having an acute MI or the patient's having chest pain, we treat it very seriously because it can lead to death very quickly if it is something to it, we leave it untreated. So at the hospital to treat it, they may give fibrinolytics, uh, so some blood thinning medication to kind of help loosen all that up and get everything flowing and good again. They may do balloon angioplasty, place stents, right? They go to the cath lab, get a cath done, and have a stent placed. Uh, Most time after an acute MI, especially after they had stents placed or anything like that, they're going to be taking aspirin or some form of blood thinner every day and a beta blocker to help keep their heart rate under control and it kind of in a restful state. So treatment of acute MI is going to be kind of similar to the treatment of ACS and coronary artery disease and other thing else you're gonna treat with cardiac. Do your primary and secondary assessment, figure out what's going on, how do they feel, make sure the ABCs are intact, get them to describe the pains to you, all those things, right? Uh, Symptoms of a acute MI are going to be is similar, if not identical, to acute coronary syndrome. So, chest pain or discomfort, trouble, difficulty breathing, nausea, vomiting, syncope, sweating. All these things are going to be pretty much identical to a patient who's having symptoms of acute coronary syndrome, right? That's why we until proven otherwise, any patient with ACS is having a heart attack until we prove it otherwise, right? So the most important treatment is transport. We obtain a 12 lead EKG if you can. If you're running a BLS unit, consider calling ALS depending on how far away you are from a hospital. Be prepared for the patient to go into cardiac arrest. Administer aspirin and nitro and monitor and reassess your patient. Some other types of cardiac issues you'll deal with, you'll have patients who are in heart failure. So congestive heart failure means the blood is chronically unable to pump blood efficiently, unable to perfuse the body tissues. As a result, exercise and other physical tasks can be limited and difficult. They cannot compensate well for any kind of challenges to their cardiac function. And because of that, because the heart's not able to pump the blood and fluids efficiently, it's going to start causing a fluid buildup. Just one second, guys. Sorry, I have children. Uh, in right side of failure, the pressure is going to build up on the right atrium, superior and inferior vena cava. With this, you'll start seeing JVD or jugular vein distension. So the vein in your neck, you'll start seeing that come out. They'll start having swelling and fluid buildup in the abdomen. There'll be pedal edema. Essentially, there's too much pressure in the chest cavity, right? There's too much pressure on the heart. So you're going to start seeing some like tension related symptoms because of that. Same with left side of failure. That's where pressure builds up on the left atrium and the pulmonary vein. Fluid's going to start leaking into the alveoli. It's going to start impairing gas exchange. That's going to lead to pulmonary edema. So it can be life-threatening. So start leading to that fluid buildup in the lungs. It's got pressure on the left side. It'll start leaking that fluid into the alveoli. The alveoli become underwater, damaged, right, under fluid. So that gas exchange can't take place. So there's no good perfusion going on because there's no good oxygenation going on. Does that make sense? When assessing and treating these patients, you want to make sure see if they have any history of heart failure, right? Is this kind of thing happened before? You're under a doctor's care for CHF or heart failure. Uh, you want to look and see if they have any medications designed to control their fluid levels. Lasix is a very common one. Patients on Lasix, ask what they're on Lasix for. Is it because they have CHF or heart failure, or is it because they have some sort of kidney function problem? Just figure out why they're on Lasix because it may be an indication that it's some sort of cardiac related deal. Pedal edema. What's pedal edema?
Swelling in the ankles.
Right. Swelling legs, ankles, lower extremities, right? Feet. That's pedal edema. That's swelling in the abdomen or buttocks, JVD. Those are all signs and symptoms of heart failure, right? Uh, you want to assess for any pulmonary edema or any difficulty breathing. See if they have any crackles or they're coughing up any frothy pink sputum. Perform your primary assessment. This patient may require positive pressure ventilation. What are two ways we can administer positive pressure ventilation?
BVM and CPAP.
Very good. BVM and CPAP. Get an OPQRST and a sample history on it. Figure out, how they're feeling, what they're feeling like. Has this happened before? Get their prior medical history, all that other stuff. Take their vital signs, perform a detailed assessment of their heart, right? So listen to them, listen to their lungs, listen to their heart tones, take their vital signs, document what you hear, and hand it off. So you want to treat the signs and symptoms. If the patient has symptoms of pulmonary edema, meaning you believe there's fluid buildup on the lungs, you hear the crackles, they have extremely high blood pressure, and all that other things like that, you want to call for ALS. Depending on your distance from a hospital, you want to try and get some advanced life support there. We can administer a few medications to help keep that under control a little better. You want to consider the application of CPAP, especially if your patient has pulmonary edema symptoms. And then you want to administer nitroglycerin, just like you would for acute coronary syndrome patient. So less common, but just as dangerous condition you may deal with is an aneurysm. So an aneurysm is when a weakened section of the arterial walls dilate or balloon out. They then burst and they cause rapid, life-threatening internal bleeding. So when these aneurysms kind of balloon out, right, the walls weaken, but the pressure stays the same. So they balloon out, they get bigger, they get bigger, they get bigger. Eventually they pop, they bust, just like a balloon when you put too much water in it. It pops, and it will result in some very severe bleeding. So see, it's ballooned out, eventually it busts. Now all that blood that's supposed to be running through that artery is now spilling out here. All right, not where it's supposed to be. So it's going to start causing some severe internal bleeding issues. It's not really a good pre-hospital treatment of that. A very common type of aneurysm that you may run in, as far as aneurysms go, that you may run in contact with is what's called a AAA. So an abdominal aortic aneurysm. So that's where arteries running through your abdomen, right, start kind of dilating, and you start feeling an aneurysm there. Some symptoms of that or some assessment signs you can look for if the patient describes like a tearing pain in their chest or their abdomen, like it feels like like it's a ripping, right? That's a symptom of that. If they have a different blood pressure in each arm, say the blood pressure is extremely high in the right arm or extremely low in the left arm or vice versa, that can be a symptom of a AAA as well. With AAA patients, you want to be very gentle in how you handle them. You want to avoid any kind of sudden shakes, movements, drops. Uh, you want to have them, ease down, do most of the movement for them. You want to avoid any kind of exertion that's going to maybe potentially cause that to rupture. And you want to transport them to a surgical capable facility pretty quickly, and then provide comfort care, oxygen, other things as needed. Any questions over cardiac emergencies? Comments, concerns, donations? Very good. I will post the a YouTube link to the chapter 20 lecture as well, since we didn't start recording until halfway through that one. That's my bad. Next chapter is going to cover resuscitation. So as we talked about earlier, the function of the heart is to pump blood. Uh, to achieve this, electrical functions and mechanical functions of the heart have to work together. Electrical stimulation is going to cause the muscles to contract. In order to pump that muscle, it has to have oxygenated blood. Without any oxygenated blood, the pumping fails. Without the electrical stimulation, the pumping fails. They all have to work together in unison to make that happen. So any kind of mechanical failures of the heart, you may have a loss of the normal heart muscle structure. All right. So whether that is through taking some sort of opioid overdose or like an opioid, have an opioid overdose where they lose that muscle tone, right? Severe trauma where they lose that muscle tone. A myocardial infarction, like we just talked about, where they're having a heart attack, right? Chronic hypertension, so their blood pressure stays too high too long, right? The heart can't function under that high pressure for too long. Direct trauma, uh, all those things like that. Any kind of pulseless electrical activity is going to indicate mechanical failure. Now, as an EMT, there's not going to be a good way for you to determine PEA. But as you get on an ambulance and you're working with a paramedic, if you ever notice you're doing CPR, you stop, you do a pulse check, right? You do a pulse check, and if you have hooked up a cardiac monitor, the paramedic will do a rhythm check. So if you ever see electrical activity on the monitor, like it looks like a regular organized rhythm on the monitor, maybe slow, maybe normal looking, with no associated pulse, that's going to be pulseless electrical activity. If you see that, it's a good indication there's some sort of mechanical failure with the heart as opposed to just an electrical failure with the heart, right? Now, with electrical dysfunction, uh, the cardiac conduction pathway coordinates electrical conduction to the heart. So there's a pathway running through the heart that coordinates how the electrical signals are given, what they tell the heart to do, how they stimulate the heart to pump. Uh, If you have a patient who's in asystole, which if you ever seen the monitor with a flat line, that's asystole, there's a complete failure of the electrical system. The electrical system is not working at all. Uh, any kind of disruption of the heart's electrical system is going to result in some sort of dysrhythmia. So a rhythm other than a normal sinus rhythm that they shouldn't be in. It's a dysrhythmia. So they may have an unusually slow rhythm or an unusually fast rhythm. There may be a ventricular tachycardia, which is VTach, or ventricular fibrillation, or VFib. Uh, a dysrhythmia, especially VTach or VFib, can lead to sudden cardiac arrest. You can have VTach with a pulse. You will not have VFib with a pulse. But you can have somebody in ventricular tachycardia that has a pulse. Uh, VFib and VTach are correctable via a tool that we carry. What is that tool? As an EMT, you have access to it.
AED.
An AED. So, in order to correct VFib or VTach, pulseless VTach, you will defibrillate the patient. So you apply the AED and administer a shot. So sudden onset or sudden cardiac arrest can be a sudden onset of a dysrhythmia, or acute blood trauma to the chest. With sudden cardiac arrest, a patient's oxygen levels may be relatively normal at the beginning. They may not be discolored. They may just look like they just passed out, right? They're still, it just happened just like that, right? So there's still some residual oxygen in the body. With an asphyxial cardiac arrest, the heart has stopped pumping due to systemic hypoxia. So the heart, for whatever reason, is not receiving enough oxygen to pump, or it's not receiving enough oxygenated blood to pump through. This can be due to a respiratory failure, a respiratory issue of some kind, being in a low oxygen environment for too long. Firefighters, we have to, be careful of this and stuff like that. Usually it has more warning than sudden cardiac arrest. Usually there's some symptoms beforehand, so some severe shortness of breath, right? Some coughing, wheezing, bad issues like that, so chronic chest pain, stuff like that is going to be kind of some warnings indicators as opposed to somebody just dropping out, right? With asphyxial cardiac arrest, quality ventilations are just as important as chest compressions with somebody who has an asphyxial cardiac arrest. Problem is, as an EMT, there's not a whole lot of ways to determine that. So we want to make sure we administer high quality CPR and effective ventilations on every patient, right? You may come across a patient in cardiac arrest who is having agonal breathing. So agonal breathing is the primal reflex during a cardiac arrest. If anybody's ever seen it, it's when a patient looks like they're kind of gasping once every, 2 or 3 times a minute, right? They're not counted as a real breath. It should never be a reason to not start CPR. And I'll post a video of agonal respirations as well. You can have somebody who has agonal respirations with a pulse still, but if you do not start providing ventilation, they will quickly not have a pulse. So if you see somebody with agonal respiration, it's important to act quickly and manage that airway. Because of cardiac arrest, the heart does not pump because it's not moving, right? So cardiac arrest means stop. So cardiac stop, heart stop, right? Because of that, the heart does not pump, the blood does not move. The cells do not get oxygen and nutrients because the blood is not moving. Organs are damaged because they're not perfusing. The organs will fail if they do not perfuse for a period of time, and the person will die if you leave this uncorrected. So with cardiac arrest, the name of the game is time. How long does it take for you to get from where you are to the person in cardiac arrest? Quickly start CPR. That's why a lot of dispatchers are trained to give CPR instructions over the phone to somebody until responders can get there, whether that's police officers, firefighters, EMS, right? Somebody get there that has a little bit more training to take over, right? Pediatric cardiac arrest. So kids do also go into cardiac arrest. It is awful, right? But the good news is they are usually reversible or more easily reversible than adults. It's easier to get a child back from a cardiac arrest than it is an adult. Reason being, most cardiac arrest issues in children are a result of asphyxia, the result of some sort of breathing issue, whether that's choking, shock, some other respiratory problem. We can usually start correcting the issue, provide compressions, ventilations, and a lot of times you can get a child back. Not always, though. It's important to identify this before it happens with children. Usually it's going to be a steady decompensation, a steady decline. So you do have a child that Initially, it was compensating and is now starting to decompensate, right? The heart rate's starting to slow down, blood pressure starting to drop, the respiratory rate's starting to drop. Try and manage those symptoms before it gets to that point, where that means we need to take over the respiratory respirations with a BVM, provide that to prevent them from going into cardiac arrest, whether we need to provide high flow oxygen, whatever the case may be. The key to a good outcome with a pediatric cardiac arrest is preventing it in the first place. So with a patient assessment, you want to avoid perceptual narrowing. You want to avoid focusing only on the patient. Survey your scene. Use your situational awareness. Is this just a regular medical cardiac arrest because your patient's 96 years old and it's just their time? Maybe. Or is this a heroin overdose? Somebody just called in, somebody wasn't breathing, and now you're in a potentially dangerous spot, right? Use situational awareness, figure out what the underlying cause was and whether or not you need additional resources there. Uh, in your primary assessment, you should detect cardiac arrest immediately, right? Because your patient's going to be unresponsive, apneic, and do not want to have a pulse. You won't go any farther than that initially. You will immediately begin CPR and ventilation, apply your AED, and going through all your BLS algorithms that y'all know how to do, right? If you identify cardiac arrest, like I said, begin chest compressions immediately. Uh, Another facet of cardiac arrest you may be called to deal with is uh, sudden unexpected infant death syndrome. That's the new way of saying SIDS. Everybody's heard of SIDS, sudden infant death syndrome. Nobody really knows what causes it usually. Sometimes it can be due to accidental suffocation or strangulation in bed. So parents who co-sleep may roll over on top of them. I've had several like that in my last 7, 8 years in EMS, more than I would care to, share. Uh, Sometimes it's due to cardiac slowdown or sleep apnea. The baby has some sort of sleep apnea, sleep condition, right? Uh, where they have some sort of issues breathing while they sleep. Uh, Eventually, they will just stop breathing and not start again. And if the infant's not reached in time to stimulate them to breathe, it will be fatal. When you arrive with a SIDS patient, if there's not rigor mortis in, which means they're not stiff, right? They don't have dependent lividity. It's obvious they haven't been there a while. Begin resuscitative efforts. Even if you think they're futile, begin resuscitative efforts. And you'll make sure you provide emotional support to the parents and get law enforcement and chaplains if you have them, counselors, whoever else, whatever resources you have at your disposal, get them to the scene because they're awful to deal with. Again, the biggest way we can prevent this is education, and the easiest way to manage this is prevent it. So with education and prevention efforts, uh, if you go into a house that has small children, notice their sleeping situation, right? Provide respectful suggestions, like especially if you have a first-time parent's never done this, well, they may never thought about it. They may just throw the baby in the bed with them. Never thought about it, right? Suggest, hey, we suggest that you do not co-sleep, right? Reason being is, you could kill your kid and die without meaning to. Ask me how I know. If I've dealt with, 10 to 15 of them. It's awful. Uh, so provide education, if you see, a crib that's packed full of stuffed animals and blankets, say, hey, we really recommend they sleep, on a flat surface with nothing around them, right? Nothing that could roll up onto or suffocate themselves with or anything like that, right? It's very common up to about the 6 month mark. It's usually when you're going to see a SIDS patient. After 6 months, you can still see it. It's not as common. So improving cardiac arrest survival, follow your chain of survival, just like in BLS, which is going to be recognition, activation, immediate high quality CPR, rapid defibrillation, BLS and ALS care, and then post cardiac arrest care. Make sure you have good teamwork, coordination, have good communication, and calm down. Everybody wants to freak out on a code. A code is the easiest call you will ever work in EMS because it's the only call where you do the same thing every time, right? It's the only call where there's not a variable that changes. If there is, it's going to be one or two medications that are administered on the ALS side, right? It's not anything it's something that is routine. There's an algorithm for it. And it's the only thing we do. There's a check sheet that you hit every single time. Every other call, it's different. It's different with every patient, right? This call, it's the same thing every time. You get there, you recognize it. You begin CPR, you begin ventilation, you apply your AED, and you get ALS to you. It's just that easy. So don't panic. There's a big push to train citizens to recognize cardiac arrest, activate EMS, and begin resuscitation. That's why you see a lot of hands-only, 20-minute hands-only CPR classes. I was in an airport in Atlanta. There's a machine in there that you can go up to, and it's free. And you just put in, push start, and it will run through a 15, 20-minute deal and has a little CPR dummy attached to the machine. And it'll teach you how to do CPR standing right there in the airport. It's a wonderful way to spend a layover, right? I love seeing it. So, uh, training the layperson in how to respond to a cardiac arrest is going to be the only way we're going to see significant uh, improvement in cardiac arrest survival rates. The efforts have to begin before we get there. If we're the first person to administer resuscitations 10, 12 minutes, up to upwards to 20, 30, depending on your response area, after the person goes in cardiac arrest, their chances aren't great. It's not impossible, but they're not great. So perform CPR. We all know what CPR does. It's, cardiopulmonary resuscitation, perform chest compressions, ventilations, right? Well, y'all know how to do CPR. Some areas you work in may have a mechanical CPR device that's available to you. Uh, and I'll bring one of these up there on Saturday for us to play with as well. Uh, so mechanical CPR devices, they assist EMTs providing high quality compression. So it's a Lucas device is one of them. Uh, So it's a big arm, mechanical arm with a backboard that slides under the patient. The arm clips on, suction cup comes down, centers up. You push start, and it just does the compressions for you. We call it the firefighter of the year. Uh, the
Jake,
all
I've got a quick question for
Yes,
you.
sir. Go ahead.
So when we ran that code a couple of weeks ago over in Shannon Hills, um, what was the reasoning why the Lucas wouldn't work on that guy?
So he was one of the very few people who was too thin.
Okay,
So the Lucas is weird in that it has to be most patients will fit it, but every now and again you have a patient who is too thin. Because that guy weighed, what do you think, every bit of 60 pounds?
maybe soaking wet.
He was tiny, right? He was old and shriveled up and cancer riddled and everything else. Tiny. And you also have a patient who was, 700 pounds, the thing won't fit around, right? So they're not perfect devices, but in most of your cardiac arrest situations are a big help. And I said I'll bring that up there Saturday, and we'll all put hands on it and go over it, and I'll show you how to set it up and everything else before you get out there on the truck with it. Uh, Another mechanical CPR device is the auto pulse. These aren't as common as the Lucas devices are. Uh, you align the patient on the auto pulse, and then you just provide BVM ventilations uh, as it thumps away, just the same as you would with a Lucas. So it's a different, has a little strap that goes around them the strap actually moves instead of a suction puck. It must have rapid defibrillation. So if there is so you put an AED on there, very quickly to see if there is an electrical problem with the heart, right? Because it will analyze and read it and determine if there is some sort of rhythm that shouldn't be there. And then it will defibrillate or prompt you to defibrillate if there is. It will charge up and give you the prompt to administer the shot. So the only times that these AEDs will work is if it detects ventricular fibrillation or ventricular tachycardia. So it's not like Grey's Anatomy. It does not restart the heart, right? It's not, we don't hook it up and push the button and, jumpstart a person, right? It recognizes two rhythms. It'll administer a shock if it recognizes those two rhythms, and that's it. It'll defibrillate energy throughout the electrodes into the patient with the hopes that outside input of electrical activity will shock the heart enough into going back into normal electrical activity and restore pulse. It's a Zoll AED. That's what our BLS units will carry here at Pafford. So BLS is the key to cardiac arrest survival, quality compressions, ventilation, rapid defibrillation, right? We always say, and we always tell new medics, BLS before ALS. Just because you have your gold patch now, just because you're a paramedic now, does not mean you need to forget your basic skills. Because ultimately, those are the most important things as the BLS level of CPR. Uh, as you go on up, advanced EMTs and paramedics may provide some more advanced procedures, such as a more permanent advanced airway, intubation, or an I-gel or a supraglottic airway that will obtain, venous access, whether that's to an IO or an IV, and give medications and fluids and things like that. A good way to kind of to work around this is make the triangle of life. So a three-person team is almost ideal for BLS CPR. So you have a person delivering compressions, person attaching and working the AED. That person's usually also going to be in like the timekeeper role and the team lead role, and then a person managing the airway and ventilating the patient. And then you can rotate these positions, right? Every time that the AED, advises to stand clear and analyze, which is about every 2 minutes. It's a good idea to rotate that so you're not getting tired, either sitting there ventilating or sitting there doing compressions. Eventually, it'll wear you out. Uh, if you obtain, if you get a pulse back on a patient, it means you've obtained ROSC. So ROSC is return of spontaneous circulation. That's why every 2 minutes we do our rhythm check, we do a pulse check, right? And if we feel a pulse, we provide supportive care at that point, whether it's continuing to ventilate, uh, providing oxygenation, whatever's needed, transport, all that stuff. Uh, so recognize that the patient's heart starting beating on their own, so they have a pulse, so they're starting to breathe overuse, maybe they're breathing on their own, right? So let's just go to evaluate that and see how we're doing, get a set of vital signs, all that other stuff. We get a pulse back. Uh, Way you manage cardiac arrest is, CPR. Make sure you have your standard precautions, wear your gloves, your mask, your goggles, your gowns, whatever's needed for that situation, right? Uh, have your AED, apply it, request ALS if you can, and then continue through the chain of survival. Use a BVM mask to deliver ventilations. Uh, Move the patient out of a dangerous area if it's safe for you to do so, if the patient's in a dangerous area. Keep the patient's airway open and clear through suction and airway adjuncts, and then interview the bystanders and family members. What was the patient doing? What happened prior to us getting here? And what were they doing before they fell out? They have a history of drug use, so I know medications, they have a medical history. What's their medical history like? So figure out any of the risk factors that could have led to this event. So we're going to start trying to identify our reversible causes and focus on those, right? Went over that already. So step one, you identify your cardiac arrest patient, organize your team, get your resources, begin your compressions, and don't move the patient unless you have to get them out of a situation. Get your AED applied, let it analyze, let it do its thing. There's CPR going, right? So step one, CPR, step two, AED. She's going to work around him putting that AED pads on. Administer the shock if it tells you to do so. Before you administer a shock, make sure nobody is touching that patient. Uh, It'll bite you, it hurts. Sometimes it will travel through metal things. So if you're leaning up against something metal that a patient's arm might be touching, say with your leg, you may get dead legged, and it's not fun. Ask me how I know. Uh, then reassess the patient every time you do a rhythm check and you change people. Make sure you do a pulse check with it and evaluate if anything's changed. Uh, After you get your AED applied, begin ventilating the patient. Uh, and then rotate that once again every time the AED comes into play. Get your patient information from your bystanders, review any physical findings. So, as the patient, do they have signs of drug use and abuse? Is there pills laying around? Is there syringes laying around? Uh, do you see pill bottles on the nightstand that maybe have some cardiac medication in them or something like that? Maybe shows a history of heart problems, right? Figure out any reversible causes and talk and interview the family members and the bystanders that may have been with them or found them to see, what happened up to this point, right? Uh, there's kind of a hot topic of whether the family members should watch the resuscitation. Should they stay in there and watch, or should they leave? Ultimately, I leave that up to the family unless it becomes a hindrance to us doing our jobs. At which point in time, I will ask them to leave, or I'll have law enforcement remove them. If they're getting in our way and not letting us provide appropriate resuscitation, get them out of there. If they become belligerent or unsafe, get them out of there. If they become belligerent to the point where the scene becomes unsafe, right? They're threatening you, they're getting violent, stuff like that, leave. All right. And if they want to know why their loved one died, well, it's because you interfered with us and you were threatening us and you were becoming violent, right? Even if just because you're a patient in cardiac arrest does not mean you have to stay there and be in danger. Okay. Uh, if the family members are able to understand or able to stay calm and they can stand to the side and they want to watch and make sure they see all the efforts that we made to save their loved one, that's fine. Just make sure you be respectful if they are doing that. Be respectful regardless, but especially watch what you say, uh, watch your language, things like that, and try to maintain the highest professional images you can, right? If you have a successful resuscitation effort, meaning you obtain ROSC, what's ROSC stand for? I'll give y'all time to Google it.
Return of spontaneous circulation.
There you go. All right. Once you get that, uh, rapid appropriate transport, continue to manage the airway if you need, and then hopefully ALS has already gotten there to you. If not, may arrange an intercept depending on your distance to the hospital, right? In a post resuscitation, check a pulse every 30 seconds. So every 30 seconds, check to see if they still have a pulse. If you don't have a pulse, uh, begin CPR again. Stop the vehicle, or if you have enough people in the back, you can continue transporting while you do CPR. Make sure your AED is still applied, administer your shots as necessary. Maybe a time where you have to terminate resuscitation. Uh, Once you start a resuscitation, you have to continue it until spontaneous circulation occurs, so you get ROSC, right? Uh, Another trained rescuer takes over for you. You turn the patient care over to a person with higher training. You're too exhaustive to continue. I've been in that situation before. Worked a patient for an hour and 25 minutes. Me and another guy on Grant County Rescue, and there's a MEMS unit coming from like Little Rock. They got involved in an accident on the way out there. Eventually, we stopped. It was 97 degrees outside. It was just two of us. Patient was in the front yard. It was just we couldn't do it anymore. So we stopped. Or if you, the most common way to terminate resuscitation is you receive a cease resuscitation order from a physician or other authority per your protocols. In Arkansas, it has to come from a physician. So you call medical control, say, hey, doc, we've done this. We've been trying resuscitation for 25, 30 minutes, right? AED hasn't shocked. There's been no change, nothing like that. Do we have your permission to terminate? And they may ask you some more questions, try to get a better picture of the patient. They may either tell you yes, terminate, or no, transport. Bring the patient to me. I want to see him. Sometimes because of that, you have to notify the family of an unsuccessful resuscitation attempt. It's rough, but be straightforward and use direct language. Don't talk in medical terms. Speak in plain English. Uh, be compassionate, but be respectful and be direct and to the point. Answer any questions they may have to the best of your ability. Uh, if it's possible, allow the family to be with the deceased patient. Take your time, be patient. Don't ever say you know how they feel, even if you do. Don't say it. But just be a person, be a human being, right? Don't be a robot. Be a human being to them. If you take over from another responder, say you're on an ambulance, you take over from a fire department, right? If there's an AED about to shock, let them shock it before you take over and put your monitor on or whatever else you're doing, and then follow your protocol and transfer of care. The initial steps of resuscitation and moving vehicle should be avoided if possible. Uh, Patient goes into cardiac arrest during transport. The best thing to do is stop the vehicle, perform CPR, apply the AED, get everything in place, and work the code in the back of the ambulance stopped on the side of the road, right? If a patient is hypothermic or submerged and that causes them going into cardiac arrest, or drowning victims or hypothermic patients, try and attempt defibrillation at least once in a hypothermic cardiac arrest patient if you can. Override your AED to shock. Uh, and then try and heat their core temperature up to at least 86 degrees before attempting defibrillation. What are some ways we can actively rewarm a patient during cardiac arrest? What are some things we may carry that can help us do that?
Blankets.
Blankets. hot packs.
Being if the patient is put in the back of the ambulance, you can turn the heat on.
Turn the heat on. Remove any wet or cold clothing, right? They have clothing that's soaking wet or icy or snow or whatever the case may be to get that off of them. So absolutely. Do not defibrillate a soaking wet patient. Get their wet clothes off of them, dry them off, dry the patient's chest, move them out of the wet environment, and then remove any kind of medication patches they may have to prevent those from burning in. Give a patient with implants, so a pacemaker defibrillator, right? Uh, you can still use an AED. So that's not a reason not to use an AED. You just place the defibrillation pad directly below it instead of directly over it. Just avoid putting it directly over it or it's going to make contact with it and then proceed as normal. Have any questions over resuscitation? Comments, concerns, donations? Thank you all. I will see you all on Saturday and I will get this video posted. You have a good night.